Okay, so welcome to the exam 2, everyone. Exam 2 covers chapters 21, 23, and 24. It's just over 2 weeks, weeks 4 and 5. So if anyone is missing the PowerPoint, will you let me know before we get started so I can make sure that you know where to get it? I gave some of my students instructions, but I just want to make sure everyone has it before we get started. So there are a couple of new terms that you definitely need to know that we discussed in the last couple weeks. So you definitely need to know the difference between meningitis and encephalitis. So meningitis is the membranes, is inflammation of the membranes that cover the brain and spinal column, whereas encephalitis is actually inflammation of the brain. So encephalitis is deeper, and then meningitis is the membranes that cover. And meningitis is it can be caused by both viruses and bacteria. We talk about bacterial meningitis more. It tends to be more severe. We mentioned, that Hib, the Haemophilus B influenza vaccine, has decreased the incidence of meningitis in the pediatric population. So there are some very specific bacteria that are out there, and immunizations do help decrease the incidence of meningitis, but not so much encephalitis, which, like I said, is actually inflammation of the brain. We also talked about osteomyelitis, which is an infection of the bone. So this is the one where we talked about, like if you have a fracture of your bone and the skin breaks, then you can get like a bacteria into the bone, which is a common way to develop osteomyelitis. You can also just really bump the leg really hard and there can be damage without there being an actual fracture. But there's almost always some sort of trauma to the bone that develops the osteomyelitis and the bacteria get into the bone. Osteosarcoma is a type of malignant bone tumor. And then it's most common in adolescents. So this is not a type of cancer that you're likely to see in adults, but you will see it in the adolescent years. And this is the one where they frequently do an amputation. So whatever bone, it's usually in the legs, it's in the long bones, then they end up doing an amputation as part of the treatment. And with both osteosarcoma and the other bone cancer, which is Ewing sarcoma, if it metastasizes, it doesn't have a good prognosis. And if it does, it usually goes to the lungs. Reye's syndrome, this is this very specific syndrome that causes encephalopathy, so just kind of mental confusion, and then hepatopathy, so inflammation of the liver. And it's precipitated by taking aspirin. And aspirin isn't a specific medication class. I don't know if any of you guys remember the name of the medication class that aspirin is in. It starts with an S. Okay, so it's the salicylate family. Yeah, go ahead, say it.
You said it already.
Okay, fair enough. Family. Yes, the salicylate family. So if you see aspirin or salicylate, you don't want to give that in children, especially if they have a febrile viral illness, because then that can precipitate Reye syndrome. So there's no immunization for Reye syndrome. There's no test for it. It's based on the symptoms that they present with that are going to be brain and liver related, and it happens in children that take aspirin or an aspirin related medication when they have a febrile viral illness. And then sepsis is a full body systemic inflammatory response. It's usually characterized by high fever and low blood pressure. It can be both bacterial, viral, and it can also be fungal. And fungal infections can be worse than both the bacteria or viral. So children that are septic tend to be really sick. These are patients that you would anticipate would be admitted into the intensive care unit. And then conscious sedation is a very specific sort of procedure where patients are given medication so that they don't move and they're groggy for a painful procedure like a chest tube placement or something like that. And they're in a one-to-one nursing assignment. So it's one nurse for one patient, and they have to monitor their airway, breathing, vital signs very carefully. So I can honestly say, as an LPN, I doubt that LPNs are licensed to do conscious sedation in any state, but you should be aware of what conscious sedation is. And then a clinical pathway is that's the interdisciplinary plan of care, which would be different than your nursing care plan. And you need to remember that an emancipated minor can sign for themselves. So this would be someone under the age of 18 who is able to sign their own informed consent and make decisions for themselves. See, these next couple slides here, they go over the theories again, because there are theory questions on exam 2. It's not nearly as heavy on the theory as exam 1, but there are theory questions, and they're worded very similar to the first exam. So they might, instead of saying, a 5-year-old is in the phallic stage for Freud, what does this mean? They might say something like, a 5-year-old boy who's attached to his mother is in what stage according to Freud, where they kind of give you a description of the stage and the age, and then you have to identify which stage for that theorist. And sometimes they'll try to blend them, so they'll put 2 theories in one question. So the thing that you need to remember the age for every stage. And then I would really remember Erikson is the only one where they put 2 opposing ideas. So Erikson is trust versus mistrust, and then it's autonomy versus shame and doubt. There's always 2 opposing factors in Erikson. So if you're asked an Erikson question, then you're going to pick a stage that has 2 things that are opposing each other. You're not going to pick one that could be the same age that would be Piaget, if that makes sense. Like they might try to trick you by combining information from 2 theories in one question. So you really need to be able to recognize the theories. Specifically, Freud and Piaget are going to be the 2 that are tested the most. And then what the stages are for each theorist and what age and what characteristics are for each one. And I know that they're confusing, and I apologize. I wish I could make it not be confusing, but there is a certain element that's memorization. You're going to need to know, okay, oral for Freud is 0 to 1. This is a child that derives pleasure from sucking. Anal is 2 to 3, your toddler years that are potty training. You're going to have to just know the basics for specifically Piaget and Erikson. So this is the exact same slide that was in the exam 1 review. So just kind of thinking, in Freud's stage of orality, the infant explores the word from their mouth. Some examples, this is a baby that's constantly putting their fingers in their mouth that really gets pleasure from sucking on a pacifier. Anality is that toddler year for Freud. They're learning to potty train, they're exercising their independence by saying no. And then the phallic stage is that preschool age when they're becoming aware of self as a sexual being. And this is where the boys are attracted to the mother, the girls are attracted to their father. And then the latency stage, they're in their 2 separate groups. The girls hang out with the girls, the boys hang out with the boys, and they don't really interact. There's not a lot of sexual desire happening. And then they'll go into the genital stage where they really start to have sexual feelings. So I think that, going over all the exams, I think that my students struggled with Piaget and sort of recognizing, that the pre-operational stage, these kids are really imaginative still. This is that preschool year where they don't understand when they got sick. They're not going to say something like, I got sick because I caught a cold, or my tonsils have to come out because I'm sick. They make magical things. I'm sick because I got in a fight with my brother. That's really that magical thinking, pre-operational preschool. Whereas when you get to the concrete operations, which is really your school age, this is understanding cause and effect. And then formal operations, which is the adolescence, this is when you develop abstract thinking. So you need to be able to identify what sort of characteristics of thought for each stage and what age. And this slide here just kind of goes over, this is when I said, remember for Erikson, it's always 2, trust versus mistrust, autonomy versus shame and doubt, initiative versus guilt. There's 2 factors that are opposing each other at each stage. So you should never answer, if you're asked, which stage of Erikson, and it's one thing, that's not the right answer, because all of Erikson's stages are 2 opposing things that are the name of that stage. And this is the one, Piaget is cognitive, Erikson is more like personality, psychosocial. So it's based on the belief that if you don't have positive resolution of each stage, then that results in an unhealthy personality starting in infancy, where you really should develop that sense of trust and hope Then you move on to toddlers. This is the autonomy versus shame and doubt. So this is where they're going to learn to be autonomous, to be independent. So they potty training, self-feeding, self-dressing. This is probably one of the most challenging time for parents because they're saying no all the time, and you want to like give them options and encourage their independence and not put too much restriction on them, because that's the stage they really need to develop that sense of autonomy. Because if they don't, then they'll develop shame and doubt. And then you go on to the preschoolers, the initiative versus school age, industry versus inferiority, and then identity versus role confusion for the adolescent. So on the slide before, it goes all the way, you know, to 65 and older. You don't need to know the last 3 stages of Erikson. Since we're in pediatrics, it's always going to stop at adolescence. And I think Maslow's like a pretty conceptually easy to understand, but I think what kind of maybe messed kids up on the first exam was being able to recognize the name of each level. You know, for example, activity is not a name on Maslow's hierarchy. So if you're asked which pyramid, you know, which level of the pyramid corresponds to a specific item, it's always going to be, you know, physiological, safety, etc. It's not going to be something that's not one of the levels of the pyramid. Like I said, I know that on this next exam, it's more heavily focused on Piaget and Erikson and not on Maslow and Kohlberg. And then we're back to Kohlberg, which is the moral development. You know, as you continue to grow older, you develop more of a sense of conforming to society, and then, you know, you're not till you're in your teens, adulthood, before you really develop a sense of ethics, what's right and wrong. I know this is not going to be tested, so I'm not going to go over too much information on this. This was on your first exam, but you're not going to see it on your second. So we talked about different types of injury to bones, sprains, strains, and fractures. So this is a good slide because it kind of goes over, gives you the words that describe the different types of fractures. And this is the slide that kind of shows you the picture. I'm going to point out a couple that I know you probably should know. So green stick fracture. So this is like, it doesn't go all the way through the bone. So this is where I'll show you the picture here. It's green stick. It's this one here. So you can see that the bone is still intact on the other side. So it could also be called like a hairline fracture. So it doesn't go all the way through the bone. The bone is bent and there's an indentation here, but it doesn't go all the way through the bone.
One of our professors said with that green stick, one of the best ways she explained it was, think of like getting a twig that's green, right? You know, it's fresh.
Oh, and you bend it, yeah.
And you bend it. All it does is bend, but it won't break.
Yeah, that's a good point. Yeah, and it's green. Yeah. And then the compound fracture, the bone actually goes through the skin. This is the one where I said it's really a setup for an osteomyelitis because the skin is broken and the bone is broken. So then there's definitely like an avenue for bacteria to get into the bone and cause an osteomyelitis. Simple, I think it makes sense. It's like a straightforward, simple here. Is it on here? They don't have it on that slide. Simple is like, the bone lines up. There's nothing out of place. So it's just kind of a straight line across the bone. And then the spiral is the one that you need to remember. That's an indication of child abuse, where it looks like someone like took a leg or an arm and they twist in opposite directions. So when you twist in opposite directions, like you're spiraling it in opposite directions, it does cause, this is the spiral here. This is, you know, the length, the angle that it breaks the bone. This is what is associated with child abuse. And then in terms of sprain, strain, and contusion, these 3 phrases are all related to what we call soft tissue injuries. So there's no break. So the contusion is tearing of the subcutaneous tissue resulting in hemorrhage. So you're going to see like discoloration of the skin. And then you do need to remember, you know, a sprain and a strain. So the strain is damage to the tendon or muscle, where the sprain is when the ligament pulls away from the bone. So it's one of those questions where they might give you the definition and you're going to have to be able to identify, what type of soft tissue injury are they describing? So you do, for a strain, you need to remember that's a muscle or tendon, and sprain is associated with when you pull the ligament away from the bone. The way I try to remember this is that like a sprain is more closely related to a fracture. Like, I don't know if you've ever like fallen and hurt your foot. You didn't break it, but you had a sprain. So the ligament is attached to the bone. Whereas the strain is really more muscle or tendon. It's a different sort of pain. It's not a bone pain. So this next one here, slide 12, this goes over the picture of the different fractures that we talked about previously. So in addition to fractures, there's other things that can go wrong with bones. Scoliosis, I think you guys are familiar with. That's that lateral curvature of the spine. It can cause problems with both shoulders and the hips, and it is higher in girls than in boys. It gets broken down based on the degree of curvature. So less than 20 degrees is mild, maybe some physical therapy. 20 to 40 is moderate, they brace, and then over 40, they're going to do spinal fusion surgery. And then Ewing's, this is the second type of cancer. So this is a type of bone cancer. And the other one that we talk about in pediatrics, that's also a bone cancer, is the osteosarcoma. Leg cap Perthes this is the head of the femur that there's not adequate blood flow, and then it can cause problems with the head of the femur. So they tend to have the painless limp. The idiopathic or juvenile idiopathic arthritis, it is arthritis, but it is an autoimmune disorder of childhood. So it has exacerbations and remissions. And it's broken down based on the number of joints that are involved. Sometimes there's also eye involvement. The main things that you need to remember is that it's autoimmune, it's a lifelong illness, it has exacerbations and remissions, and it's widespread, kind of all over the body, eyes, fever, and then joint pain. And then for some reason, osteosarcoma is the second, it's not up there with Ewing's. These are the two cancers. And then the Duchenne's muscular dystrophy, we briefly talked about Duchenne's and Becker's. This is this progressive autoimmune disorder where they progressively use their ability to walk. So these kids are, you know, they're unstable, they have an unstable gait, they fall a lot. The thing that you need to remember that's kind of makes Duchenne's different than other sorts of things that we talk about, this is only in boys. So it's called an X-linked recessive genetic disorder. So mothers pass it down to their sons, but mothers are carriers, they don't have the disease. So you definitely need to remember that Duchenne's is only present in boys. You're only going to see Duchenne's muscular dystrophy in boys. So traction is what we do to realign a bone that's been broken. Most commonly in pediatrics, we do skin traction, where we wrap something around the extremity and then hook that to the weights, so we don't put pins into the skin. And I think I know I told my class, you know, you have to remember Bryant's is for the young kids, and then the older kids are either going to be Bucks or Russell. So you realign the bone that's involved, you immobilize a fracture, you can eliminate muscle spasms, we didn't talk about it much, but you can also do skeletal traction. So you can pull the head and cervix back into alignment. Also in my class, we talked about the traction for your legs. So the main thing with traction is the nursing care, is the neurovascular checks. So, you know, if you're ever given a priority question, you're going to be worried about decreased perfusion, decreased sensation, et cetera, below the level of the injury, and to remember that it is normal for there to be pain. So if you were to, you know, if you were asked like which of the following symptoms would be the highest priority, it would be something along the lines of, you know, the pulse isn't as strong, there's delayed calf refill, the extremities cool, they don't have normal sensation, etc. So this is a picture of the cervical traction. So it's used to pull the head up to realign the cervical spine. So cerebral palsy is something that we certainly see in pediatrics. It affects movement and muscle tone, and there can also be mental retardation. And it's most often caused by lack of oxygen during delivery, but it can also be like an intrauterine stroke. So when the brain is developing. So they have like a combination of being floppy and rigid, abnormal posture. They also have involuntary movements. They can have contractions, so they can't like pick up pencils and pens, etc. And there's some key words to remember. So CP is cerebral palsy. Athetosis is involuntary purposeless movement. So they kind of shake. And then spasticity is they're kind of drawn in. And then this big word down here, this apoptosis, this is where they have this really abnormal curvature of their spine. So you can
Professor,
see.
can you go back over those? I'm sorry.
Yeah, no. So and this one here, so the athetosis, this picture on the side kind of shows you. So it's involuntary purposeless movements, almost like something you would see in someone that had Parkinson's, where they just kind of they move and they can't control it. And so they kind of like, if you can see my hand, they might just kind of go like this all the time. And they tend to have abnormal position of their fingers also. And then in terms of the spastic, so it's increased muscle tone and contractures. So you can kind of see, this is when they're kind of drawn in. It's not, this spasticity doesn't really have to do anything, a movement, it's they're too tight. So for this one, they can actually do what they call a tendon lengthening surgery, where they try to relax the extremities that are too tight.
Like they cut them?
Yeah, they do. It doesn't always work, but they can do a surgery where they go in and cut the tendon so they're not as, and then they can stretch them out a little bit so they can get some more movement in their feet. And then this word that I have a hard time pronouncing is this apoptosis, is this abnormal curvature of their spine. So you can see kind of the what I think is really the hallmark is the spasticity. This is what really affects their movement. They're just, a lot of times they either are wheelchair bound or they need crutches. So in terms of pain, we talk about pain and opioids and the best way to treat pain. So this is the FACES scale. So this is going to be appropriate for ages 3 and older. So you have to be able to, the kid has to be able to really communicate and talk to you to pick their face. Whereas the FLAX scale you can use in younger kids, and it's 1 through 5. So you have face, legs, activity, cry, and consolability, and they get 0, 1, or 2 points in each of these 5 categories. So it ends up converting to a 0 to 10 pain scale. So if they got a 0 or no evidence in pain in all 5 categories, their pain would be a 0. Or if they got a 2 in all 5 categories, their pain would be a 10. So when you use the FLAX scale, you still put it on a 0 to 10. And the same thing with the faces, but the faces is they pick the face that represents their pain. So in general, pain is whatever the patient says it is, wherever they say it is. So this is trying to get at that we believe patients when they say they're in pain, even pediatric patients, and then we treat their pain appropriately. And then this general question about why is pain considered a vital sign? So we call it the 5th vital sign. Why do we think we pay so much attention to pain?
Because that's what's going to affect your other vital signs.
Yeah, it does. It affects your other vital signs. Yeah, very good. And it's something that's kind of missed, right? Like if you're not really monitoring for pain, they could have pain that you're not treating. And then once that happens, once the pain kind of starts, it's harder to get it under control. So a lot of times nurses, I think because of the opioid crisis, are hesitant to use opioids. So in a hospital setting, we do treat moderate to severe pain in children with opioids. So if you're asked a question about like what type of pain medication, if for somebody who's in severe pain, it's going to be an opioid. It's not going to be Tylenol. And then the best way to administer this is going to be like, around the clock, a low dose medication that kind of keeps a steady state of the medication in the body. So you're not having these peaks of pain that you have to really give a lot of medication to treat. So low dose around the clock is the most effective way to treat pain. And then we said opioids, moderate to severe, and then acetaminophen is the most common for mild to moderate. You can use lidocaine, which is as a topical anesthetic for things like IV placements or blood draws, where you numb up the area where you're going to put the needle. We talked about conscious sedation. This is a patient that's in a one-to-one nursing assignment, and they have to be monitored very closely. And this is on here. I don't think we talked about it in my class. Does anyone know what flumazenil is used for?
Isn't it the antidote for benzos?
It is. And what's the antidote for opioids?
Narcan?
Narcan. So I would remember both of those. So I think you guys know this. When does discharge planning begin?
The beginning.
As soon as they come in. There are questions on this exam about the stages of separation anxiety, which is the same sort of question that you guys answered in your discussion post this week. So you do need to be able to kind of identify where they are. So that protest stage, they're really crying out a lot. The first 1 to 2 days that mom and dad leaves and they're crying, you expect them to cry out a lot for their mom and dad. And then when they're in the denial phase, what are they like? What do they do?
They ignore them if they come back.
Yeah. And then the despair phase, I kind of jumped ahead. So what's the second stage? The despair stage. What are they like?
Don't they just shut down? They shut down, don't they?
Yeah, they're just sad, but they're not necessarily crying out. Yeah. So, when they're crying continuously, that's the protest stage. And the denial or detachment, and they're kind of ignoring their parents and they're playing with the toys. And the despair stage in the middle, they're not to the point where they're playing with the toys, but they're not crying out all the time either. And then how can we promote security while hospitalized? So there's a couple things.
What about detachment?
So denial or detachment are the same. That's the same phase. So there's not 4 stages, there's just 3. So protest, despair, and then denial or detachment, that's the last stage. So if you're asked like the best way to help with separation anxiety, what do you think you tell? Like if a child is having separation anxiety in the hospital, what do you recommend as a nurse?
Have the parents stay with them as long as they can.
Yeah. So encourage the parents to be there as much as possible. There's other things that you can do that might help, but the best thing to do is for either the mom or dad to be there. And then other ways to promote security, we call them transitional objects. A favorite teddy bear or a blanket from home can help them feel more secure. You can reduce anxiety by having, incorporating their daily routine as much as possible, so it's not so strange for them. So we talked a little bit about, altered level of conscious, different things that can cause altered level of consciousness. One of them is being like a low blood pressure. You're not getting enough perfusion to your brain. Also like things like a low oxygen level. So making sure that if kids are seeming a little bit different, if their level of consciousness is changing at all, that there's a lot of different things that could cause that, and you need to be paying attention as a nurse. And there's certain things that you can do, calm, reassuring with parents. If the kid's really sick, you still need to stay calm. You need calm, matter of fact, straightforward. You want to maintain that sense of trust. You want to try to do individualized care as much as possible, incorporate the home habits, and then, using play that's appropriate per the age of the child when they're in the hospital. So we talked about the eye. So, remembering hyperopia and myopia, farsightedness versus nearsightedness. Conjunctivitis is just an inflammation of the mucous membrane. That's where you have like that really red eye, and then you tend to have that kind of yellow greenish discharge. It's very contagious. It can keep kids out of daycare. They do treat it with antibiotics. And then we talked about these different, so amblyopia and strabismus. So this kid looks like he has amblyopia. So do they put the patch on the good eye or the bad eye?
The good eye.
They put it on the good eye to force the brain to use the bad eye. So nystagmus is that eyeball is moving. So it's like jerking back and forth. Sometimes you'll see this with seizures. Sometimes you'll see this as a reaction to medications. This is not going to be treated with a patch or anything. You need to figure out what the cause is. And then once you figure that out, you can treat that and this nystagmus should stop. And then papilledema, this is what you actually see when you look into the eye. You might see this with something like shaken baby syndrome. So when it's edema of the optic nerve. So the optic nerve is cranial nerve 2. So if there's inflammation of that nerve, when you're looking through the pupil into the back of the eye, you can see that. So in terms of the ear, in terms of hearing loss, I would remember the different types of hearing loss. So congenital is something that you're born with. So that's the general word for congenital. Congenital means you're born with it. So it could be hereditary. They could develop, passed on from child to parent, deafness, or it could be something could have gone wrong during the pregnancy that resulted in hearing loss. And it's strange to me that I speak English as a first language because there are several words that I just have a hard time saying. So sensorineural is when there's damage to the hair cells along the cochlea and the acoustic nerve, and in it, so this is the type of hearing loss that you're going to develop over time. Like if you're constantly exposed to loud noises, and then over time you develop hearing loss, that's this middle type. Whereas conductive is when there's the tympanic membrane prevents sound from entering the middle ear. This is going to be the kid that has like the repeat ear infections, or maybe a buildup of earwax that just prevents sound from passing across the tympanic membrane. That's going to be conductive. So you do need to be able to recognize, like if you're given a definition of the different types of hearing loss, be able to pinpoint what type of hearing loss that is. And then this is some basic information about how you approach a child that has hearing loss face to face, making sure that they can see your lips, establishing eye contact, talking in short sentences, and not using a lot of exaggerated facial expressions because that can make it harder for them to understand you. And then what's an acute infection of the external ear canal? Do you guys remember that?
Swimmer's ear.
Swimmer's ear, and what's the other word for it? So that is the otitis externa. And then the acute inflammation of the middle ear, what is that?
The otitis media.
That's very good. So that's the otitis media. So you do need to remember which one is which. So the otitis media, which is you see frequently in kids, that's treated with broad spectrum antibiotics, usually for 10 days. So as a nurse, you're going to need to make sure that parents know to take the full course of the antibiotics so they don't stop early. And we talked about in my class, like the eustachian tubes, they're really a setup for otitis media because the eustachian tubes can't drain the fluid from their middle ear. And then in terms of seizures, just generally it's uncontrolled electrical activity between brain cells. And sometimes people have a seizure disorder. Sometimes they can have a seizure because of a high fever or hypoglycemia. So not all children that have seizures have epilepsy, and not all seizures are alike. You do need to kind of recognize the general categories. So grand mal is the one that I think you're probably the most familiar with. This is the one where they fall down to the ground and they have full body jerking, convulsing of extremities on both sides of their body. They can also have loss of their bowels and bladder. And when they wake up, they have what we call a postictal phase, where they're kind of confused. They might have slurred speech. They can be sleepy. So both grand mal and petit mal are actually generalized seizures. So they happen on both hemispheres of the brain, but petit mal are very, very different. They're also called absent seizures, and the kid just kind of stares off for a few seconds and then they come back and then they stare off. sometimes kids that have Petit Mal actually they get worked up for attention deficit disorder because they're not paying attention for a few seconds. You can't talk to them because they're having a seizure, but there's none of the body jerking movements or anything like that. It's just like complete loss of attention for a few seconds and then they come back. So the Grand Mal and the Petit Mal, the two that have the word mal at the end, these are your generalized seizures that involve electrical activity in both hemispheres of the brain. And the Grand Mal is the really big one that involves the jerking, and the Petit Mal is just like it looks like they're just not paying attention to you for a few seconds. And then Jacksonian is also a simple seizure, and it's just going to be on one side of the body. They usually stay awake. It'll be like an arm twitching or something like that, and it's just on one. It's unilateral. Myoclonic spasm or an atonic seizure, this happens on awakening. So they wake up, they collapse, and they recover in a few seconds. Status epilepticus is a seizure that lasts for more than 30 minutes. So this is when you're really going to be concerned about, like, they're not going to be breathing, they're going to have a hard time managing their airway. They almost always end up going into the ICU when they have any sort of status epilepticus. And the postictal period is that period of time when they're coming out of a seizure, when they're kind of off, sleepy, groggy, confused. It can be scary for parents, but it's a normal thing that tends to happen, especially after a grand mal seizure. So infection, something like meningitis, reaction to certain drugs, having epilepsy and hypoglycemia can all cause seizures in children or adults. You need to kind of remember your basic priority of nursing care if someone that has a seizure. So side rails up, either their crib or their bed, nothing around, any sharp objects around the bed. The parents need to make sure the child always wears a medical ID bracelet, not just when they're in the hospital. And the medication regimen is really important. If they have like a continuous level of their medicine, their anti-epileptic medication in their blood, they're less likely to have a seizure. So medication compliance is important. And then they might need some extra supervision, playing sports or around water, because they could have a seizure when they're out playing. So there are 5 math questions on this test also. So I hope that, if you want to, I know there's the math worksheet and the video, but it's going to be the same sorts of questions that you saw in the last test. The same processes, the same concepts are going to be tested again in terms of the math. Do you guys have any questions? No, did everyone get a chance? So I posted Dr. Bogart's math review and I attached the math worksheet. So I would encourage you, for anyone that was struggling with the math, to look at that also. And I will post my review and the other Rebecca's review today. Good. Does someone have a question?
I have a question. It's Lanice.
Yeah.
Where did you post these slides at?
Which slides? The ones that we just did today?
Yes.
Yeah, they're on the initial announcement that says exam 2 review times. I'll let you find it before we get off the call. I'm going to stop recording though.
Okay.
Go ahead and look for it. Make sure you can find it, Lanice. And if you can't for some reason, then I'll send it to you.